Hello. So as I've been working in my current post for the past year. Previous to that, I've been working as a GP practice pharmacist for the past 10 years, and that's given me the privilege really to work with a huge range of pharmacists and clinicians and patients across the length and breadth of Wales, but also I've been privy to seeing a lot of different prescribing practices across different clinicians as well. So my remit today, thank you for the opportunity to talk here, is to talk about deprescribing in a GP practices. So before I can talk about deprescribing, what is the problem? The problem is polypharmacy. Last year when I studied for the Diploma in Therapeutics, I was privileged to listen to lectures by Dr. Martin Dewardin, who works for the King's Fund, who have coined phrases for polypharmacy in terms of appropriate and problematic. And the key thing that I remember from his lectures is him saying that when he qualified, polypharmacy was frowned upon, and yet now it's the norm. So key things that come to me is the third point on the slide in terms of does a patient really, can they really have the capacity to manage complex drug regimes? I certainly wouldn't be able to. In a patient perspective on taking medicines, do they actually want to be taking these? About a fortnight ago, a patient was booked into my clinic and I asked for a polypharmacy review, and I asked him to produce his medications. He produced me a Nomad box that was half full, and also a kitchen towel full of about 150 white tablets. So this is where we're at and what we're trying to achieve. So part of that consultation were two things. I rationalised his medications and stopped some, and also changed it to a BD dosage regimen. But the biggest intervention I made was to get his nephew's girlfriend to agree to go to his house. She lived on the same street twice a day to help him administer his medicines. So from a polypharmacy review, it actually became a social care intervention. So things that are acknowledged is that multimorbidity and polypharmacy increase clinical workload. We know this at a time where NHS sustainability is challenged, but also they need effective multidisciplinary teamwork and clinical skill mix. So we can't just work alone on polypharmacy reviews. So in the words of my GP lead, the problem with polypharmacy is prevention is better than cure, but it starts off with all our training in that it's problem focused. Various doctors are adding something because they are generally trying to help a specific problem the patient is there for, without looking at the patient as a whole and focusing on their own speciality. But that is the structure of the NHS. If we want special opinion, we can't send a patient to a specialist and say this patient is in chronic pain, but actually they're hypothyroid and they're hypertensive patients, so actually I'm just going to leave them alone. That isn't just what happens. So almost we need a culture change in prescriber behaviour, where doctors are trained to be problem solvers. We all are to a degree, and the provision of prescription is a customary action and most of all expected by the patient. So when does it happen in practice? For me, this is standard reactive deprescribing. So following an adverse drug reaction, a formal medication review, patient request, do I need all these tablets? Secondary care interface. So when we're dealing with the discharges and the clinical letters, these things are happening all the time. But this is reactive, and I'm actually more interested in proactive deprescribing. So my interest, this again is a definition of deprescribing. Systematic process of identifying and discontinuing drugs. King's Fund are not fan of commas, I'd just like to say. It's a systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of an individual patient's care goals, current level of functioning, life expectancy, values and preferences. So that is what it is. We have toolkits that help us in training here, but I'm going to refer to the aviation industry here. A quote from Otto Lilienthal, the pioneer of aviation in the 1800s. To invent an aeroplane is nothing, to build one is something, to fly is everything. So to coin a phrase is nothing, with all due respect. To build one is something, so the toolkits we have is good for our training, but what we actually do in practice is what counts. So to fly is everything. So my particular interest in deprescribing started a couple of years ago now, and I had the pleasure of working with the brilliant Laura Davis, who's been snapped up by Furness House Surgery at Carmarthenshire. So the remit of our work as cluster pharmacists was to identify high-risk patients and conduct polypharmacy reviews. So this is a crude analysis, and it was just a snapshot of the work that we did, which we had to provide for the funding of our role. But the thing that's concerning to me, although it is very crude data, for 26 patients we stopped 20 medications. Now there's two ways to look at that. I acknowledge it's crude data, but almost 80% of patients were on one medication that they didn't need to be on, or more worrying for me, less than 80% of high-risk patients, so a smaller percentage, were on multiple medications that they didn't need to be on. And these ranged from, this is what we presented, two ones that particularly stood out to me is I did a home visit for a patient who was bedbound, couldn't even sit up, and was on a biphosphonate. So what were we doing there other than burning holes in our esophaguses? But also, it was an indwelling catheter, and she was on prophylactic antibiotics. So what were we doing here? That's just a waste of resources, if not anything harm to a patient. The second one that stands out to me for two particular reasons, I did a home visit to a patient, a very rural location, a retired farmer, who, just because of his rural location, the carer would administer temazepam at 5 o'clock in the afternoon. He would sleep soundly at that point, and his quality of life was affected because he woke up to the closing credits of Pobl y Cwm. So he was not happy about this. But on top of that, he would then trip on the way upstairs to bed, was awake all night, but the biggest thing was he was anticoagulated, falling daily. So I came back to the GP surgery and spoke to a brilliant GP, Dr. Neil Windsor-Jones, who was previously a brilliant pharmacist. He retrained, and he was in complete state of shock because he had visited the patient just a couple of days earlier for an antibiotics prescription because the guy had a chest infection. But he didn't know anything about this huge risk that this patient was being exposed to. It was only by working as a team that actually came to light. So at this point, you've heard this from every patient at some point. What would Nye say about all of this? What has he achieved? Or what is the legacy when in that snapshot for across these surgeries, that out of 26, 20 patients were on medications they didn't need to be on? So what we took from that, three pharmacists, because we had to forge our roles at this point, was where was our place in practice? So together with the GPs, when we were now analysing our work, we soon found that this patient who had been on the temazepam, their home visit, and was anticoagulated, he fitted the case management, the top part of the pyramid for population disease management. And this is what the GP recognised that he'd missed. So instead of basing our interest on the middle level, the care disease management, you have nurses in practice who are doing that very, very well. So if you've got these new pharmacists going into practices, and in effect we're paying the second highest to the GPs in the practice structure, we should be aiming our interest more at the case management, because that's a better use of our skill. This is recognised again in the BMJ in 2012. Does current GP consultation model and QOF allow comprehensive assessment or anticipatory care in older people with complex needs? And some things, just via the current structure, remain undisclosed or they're not addressed. So, deprescribing, why are we doing it? This is decade-old data now, but 17% of hospital admissions are due to ADR, so at least that by now, versus 6.5% incidence in the general population. Now, anybody working in primary care knows that that has to be an underestimate with regards, it's just a matter of recording and how we go with that. Now, this is another pyramid diagram, but it proves a different point. This is the Heinrich pyramid from the 1930s. It's industrial accident prevention. Now, deprescribing can be, we've all come across it in terms of therapeutic inertia, which isn't appropriate, to be honest. Everybody's come across a prescriber, regardless of the background, that asks the question, when you want to optimize medication, is the patient stable? At which point you know the conversation is finished. So the point is, if we can deprescribe as much as we can when we can, we're at the bottom of the pyramid. We can avoid more of the near misses that prevent the serious harm at the top of the pyramid. So that's why we should be doing it, and actively doing it, and proactively instead of just reactively doing it. Also, about a year before we started doing the deprescribing clinics, it's worth mentioning that the law on informed consent was redefined by the Montgomery case in the Supreme Court. So medical paternalism has been replaced by a value of self-determination in the internet age. So the previously accepted model of the doctor-patient relationship no longer reflects reality. Patients are coming to the consultation already knowing a lot before they ask for your advice. The patient is no longer a passive recipient of medical treatment, but a partner in the provision of that treatment. And the objective test of the reasonable doctor, the Bolam test, has been replaced by that of the reasonable patient. So we should be taking that into account. What I found from the deprescribing, the polypharmacy deprescribing clinics we're running is if we deprescribe something, we better well had follow-up. So if we stop a blood pressure medication, then we need to arrange that the blood pressure is checked. So that has to be a move in practice that we are following through. Patient capacity, you have to judge, such as the gentleman with the kitchen roll full of tablets. There wasn't much point to me discussing the pros and cons of his medicines because he didn't have the capacity to take that in. Patients are also coming, as I said, more educated to the consultation. I think such as lifestyle medication movement has a big impact. There are TV programs now, the brilliant TV program by Dr. Rangan Chatterjee, where the doctor actually goes and lives in the GP's home and shows that aspects of their lifestyle are actually worsening their care. So it puts more responsibility back onto the patient rather than thinking that there are just magic pills. What also came apparent was things like immunity to change. This is a concept by Professor Robert Keegan in Harvard University, which shows that every patient has a holding environment concept, which is linked to this social identity. So if a patient, for example, lives on their own, does the majority of their socialising in the pub, they go for a pint every night, if that is their social environment, then it'll be very, very difficult to get them to change that aspect of their personality if it's strongly linked to their identity. And also, I don't know if she's here today, Emma Davis has written some wonderful articles on motivational interviewing skills. I think that's something that we may need more training in terms of how to actually get that change across the patients. So I tried to think of an analogy. How does deprescribing feel? So this to me is how it feels. So these are statues in New York of the fearless girl and the raging bull. Now, many times when you're telling a patient, and they don't expect this half the time, that you're thinking of stopping medication, often I feel that I'm the fearless girl and they are the raging bull. Because how dare I even discuss this? They've been stable on something for the past 20 years. But having done reflective practice, looking at how it's been, I would say sometimes, if I put myself in the patient's seat, perhaps I am the raging bull, and perhaps they perceive themselves to be the patient, the fearless girl, because I've suddenly asked out of the blue, and they have great belief in this medication because the doctor that prescribed it, they got great belief in them as well. This is a belief they've had for a long time. So this is a case study. Last summer, we received a new patient arrived in practice accompanying with a letter from Professor Kia Lewis, who's a respiratory consultant in Hywel. It read along these lines. So she was 44, a new patient. She did not have a history compatible with sleep apnea, but is extremely tired. I'm quite concerned about the doses and the amount of drugs she's on, including gabapentin, nortriptyline, cocodamol, propranolol, tramadol, Zomorph, and fexofenadine, which can all cause tiredness. We were in shock, to be honest, when we saw this letter. She is also prescribed betahistine, possibly for drug-induced dizziness, and laxatives for drug-induced constipation, the prescribing cascade. She also takes naproxen and gets gastritis, so she takes omeprazole, which is also associated with sleep disturbances. I feel this polypharmacy is causing more harm than good now. I believe only with multidisciplinary input and less drugs can we improve this young lady's quality of life so she can look after her disabled son and hopefully try to start working again. She appeared very happy with this new plan. Now, everything there he said is reasonable, except for the last sentence. Because when she presented to us, she was the raging bull. This was not what she had in mind at all. So she presented to the F2 doctor, face-to-face medication review. He didn't want to deal with this. So it was handed to me, and I wasn't quite up for face-to-face, to be honest. So I conducted a telephone medication review and told her basically this is the plan. This is what we've agreed to over a series of months. This is how you're going to come off these medications. It wasn't done overnight, but it was a 6-month plan. Followed by one GP face-to-face medication review, followed by another. She sought another GP face-to-face medication review. But luckily, as a practice, we stuck together. So all of this is sorted, hunky-dory, except a recent, in the past month, secondary care correspondence. Although I fully appreciate the addictive potential of diazepam, there's no doubt that a small dose does have a significant effect in problems with muscle tension and spasm are one of the main features. So here we go again. We're back on the roundabout. But a clear thing as well is this patient clearly wanted to be on these medications. She's been referred to rheumatology recently, and the rheumatology letter includes in the current medication list, it's actually the outdated medication. So we had to contact them to say, actually, you've got a skewed perception here. She's not on these any longer. So the behaviour change in the patient hadn't altered. So, talking now about opportunities to deprescribe in practice. Now, I'm heavily involved in diabetes in our practice. I don't see the patient initially, the doctor does, but then I diagnose based on the blood tests and do the medication review before the patient comes to see the nurse. So, deprescribing in diabetes is pharmacist heaven. It's wonderful. We have these targets, everything's black and white, there's very little grey, other than if you're over the age of 65, which a lot of people are, but you're using your nous then. There are particular ones that we look out for. Beta blocker and thiazide are diabetogenic combination. Again, I'm reiterating, if you stop anything, you've got to follow it through. The same then going on to CVD prevention. I'm just looking at diabetes, how I do a medication review. Smoking cessation has to be deprescribing because we're stopping a drug. And that would have the bigger impact than a lot of medications that we give out. Lifestyle modification, where we're thinking of doing statins, actually when you look at the Curious score reduction, smoking cessation will bring it down lower than if you start somebody on a statin. I would point out that this is my working knowledge of drugs. This has gone beyond the guidelines now, so don't quote me on it. Everybody has their own working knowledge. Patient over 90, I would always ask them, do they really want to continue talking about the pros and cons of statin therapy at that point? HbA1c reduction, again, there are rules to this. If you have a patient whose HbA1c is, say, less than 40, and this is a crude analogy, but if they then go on to have an acute kidney injury, and say they're on metformin, they then develop lactic acidosis, you are cooked, because it's not indicated in the first place. It was indicated at some point, but it's not currently indicated. So we should not shy away from deprescribing. Another simple issue for deprescribing, if you've got a patient who's feasting for Ramadan and then has Eid afterwards, what we tend to do then is repeat the HbA1c a month after Eid, where everything's stable, the impact of the fast is stabled, and often we're finding that we're deprescribing as a result of that. Preoperative assessment, don't even go there. Even if it's obvious to deprescribe, if a patient's HbA1c is over 69, the surgery is in question. So there's nothing worse than you getting involved and messing with the patient's medicines, and then the surgery is cancelled. So you've got to know when to do it. So as I said, renal, again, this is wonderful for a pharmacist. It's black and white. It's fantastic. With BMI, we're having more and more patients come into the clinic saying, what about Dr. Michael Mosley? Because they all watch him on television, and the 8-week reversal of diabetes. Currently in practice, I'm diagnosing between 1 or 2 type 2 diabetics a week. So that is a diabetic epidemic. That's badness. To think that we could that we've got the capacity to give someone who's diet controlled versus somebody with HbA1c of 110 the same level of care, it wouldn't be appropriate anyway. I think there's a lot of talk in the BMJ at the moment that there'll be a new category, which is diabetes in remission, where we downgrade the care that we offer to them. I've also undergone merit training recently, whereby they actually show you how to adapt somebody's and deprescribe insulin as they are doing serious weight loss or if they uptake serious exercise. Moving on to respiratory. Patients hate changing inhalers. They say, I've been on this inhaler for 20 years. So one way we're trying to get around it in our practice is to use the in-check dial assessment. So the first thing they do at the start of the respiratory assessment is to do that. And we say, do you know what? This isn't the best inhaler for you now. So we're trying to make it a bit more scientific. Because with diabetes, once you tell them actually your HbA1c is this, they accept it as science. So if you show them actually via this assessment, you shouldn't be on an inhaler, you should be on a DPI at this point, then we're finding that is more useful to us. Also, I went on a course by the Royal College of General Practitioners who said, how long are we going to invest in low currency interventions, asking the 3 asthma questions and doing spirometry each time when we know that the things that are going to make a difference is smoking cessation, pulmonary rehab and flu vaccination. They're the high currency and they have high impact. So we have to question how we're structuring our care. Then obviously for deprescribing for asthma, the step down, we all know about these things, and overuse of SABAs. So, these are all black and white that I've spoken about so far. I'm going to talk about 5 areas here that is completely grey. Okay, so we know that gliclazide is not a great drug, it's fallen out of favour, and we want to stop it. We're thinking about population medicine rather than personalised medicine, because a lot of our patients were not testing their blood sugars and they're driving. So the last thing we want to, I don't want to be knocked down because somebody's on gliclazide, they're not testing. So we start going about it and we say, right, if your HbA1c is controlled, what we'll do is we'll just take the gliclazide away and we'll reassess you in 3 months' time. By which time, the patients have gone in a complete panic and they see different GP and they're back on it. So we had to rethink our deprescribing there. So what we do now is we replace it with one medication with the aim to deprescribe in 2 or 3 months' time, because that's the only way we found acceptance with the patient. But in the majority of time, the patient there was the raging bull. Definitely that didn't come across as very good for us, and but we held our ground. One particular patient, we switched from gliclazide. I'll remember this patient's name until I retire, and beyond probably. We changed him from gliclazide and we put him on an SGLT2. Now, completely out of the blue, he had an AKI. As a result, his renal function didn't allow the SGLT2 to work. It's not nephrotoxic, it's just it didn't work. This patient had an AKI and hyperglycemia. So that was just part of it. But what I'm trying to say is it's not neat. It's not black and white. These things do happen as part of it. So, GLP-1. We've had all this information that GLP-1s, you can use them as low, liraglutide, you can use it even if GFR is 1. So this became another treatment that we could use, ideally. So I found myself in a position where we put an 83-year-old on dulaglutide because she had reduced renal function, and we thought she would manage a weekly injection better than a daily injection. She then proceeded to have profuse diarrhea, and which then would last a week because it's a weekly injection. And in the telephone call, and I'm discussing this with her and saying, I'm sorry, yeah, it's going to last probably a couple more days, and I want to order Usinese to exclude an AKI, I found myself the next sentence saying to her, but you could try the daily if you wanted, which is crazy. Thinking to optimise medications in an 83-year-old if you've had an adverse drug reaction to one. But it is so much easier to think that the patient is going to gain from things. I think we want the best for our patients without always sitting back and saying, do you know what, it's much harder to have that conversation saying enough's enough, probably nothing is the better thing for you now, which we all need to get more used to doing. So in that case, I would say that I was probably, in reflective practice, I was that bull. And the patient was saying, do you know what, I don't want to be on injections any longer. So DOACs, we've had great success in terms of patients with weight over 120 kilograms. We've had 3 patients who, because we've told them there's lack of trial data to support efficacy after 120 kilograms, over the past 3 months, they've lost, this is actually inaccurate, it's 42 kilogram weight loss in about 55 days, because people have been given the chance, the empowerment to say, right, okay, I want this drug to cover me, I will lose the weight. And this is what they've done. So I think that's been very good. We've also used self-monitoring of blood glucose to aid weight loss in those 3 patients. If you don't have any blood tests, obviously you can't keep on going with the NOACs because you can't show that it's safe to prescribe. But also, as a practice, we've adopted a new guideline in terms of if creatinine clearance is less than 20, not 15, as all the guidance says, then we stop prescribing and we transition to warfarin. Because we had a patient who I measured at 3 monthly intervals, so GFR was 17, and then at the next interval, it was 12. So if the exit route from the body is blocked, it can't leave. So it may be to the guidance that it's 15, but as a practice, we've decided to adopt a higher level because we think it's safer in primary care. So what I'm saying is here is we saw eye to eye with the patients here. The only time that we've had this sort of reaction is when we had a consultant who wanted, in a dying patient, to keep on administering low molecular weight heparin. And this battle went on for about a month, at which point we just stood our ground and said, no, we're not. Because if we were if the choice was in our court, if we took over full care of the patient, our choice at that point would be to deprescribe prophylactic medication in a dying patient. So other opportunities in the DOAC reviews, I'm stopping a lot of SSRIs because I'm allowing the patient to make an informed choice. Are you still feeling that your depression is that bad, or would you like to stop it? Alcohol reduction, NZ stopping. Again, we see eye to eye. And then this is work-based that Emma Davis has done that we've implemented in our practice. Anybody who's on more than 120 milligrams of morphine, we've actually got together a multidisciplinary team consensus, and we've been reducing them down to the 120 that is recognised by the Faculty of Pain Medicine. We're doing that at the moment with the help of Beth. And patients are not happy. There's no doubt about it. Patients are not happy when you tell them that you're going to stop their morphine. That's just a given. You just have to go with it. Now, beyond medication in terms of deprescribing, lifestyle modification. If you can get patients to stop smoking, reduce food intake, reduce alcohol, we are basically stopping chemicals, basically, aren't we? We're just stopping drugs in a format. But it's probably more effective than what we're doing with medication. Reduce treatment burden. Annual MOT for chronic disease patients with comorbidity. So it has to extend past medication. We have to think of NHS capacity and workload. Why are we calling someone in for 5 blood tests a year because they've got comorbidity instead of just doing the annual MOT? Another thing to consider is under-prescribing. We had a patient recently who joined the practice. When we did an analysis, it was a paediatric epileptic patient who wasn't on any anti-epileptic meds, despite secondary care letters saying that they were. And what it was, the parents thought that the child was sedated in school and wasn't progressing in school, so decided to stop the anti-epileptics, despite the fact that the patient was still having seizures and was still having incontinence as a result of the seizures in the school setting. So it can't just all be about deprescribing. We've got to look at the appropriateness of what's not there as well. So I've covered this quite a bit, deprescribing, barriers to it. Unless we go about it in the right way, people may think that we're going at it like a bull in a china shop. But it's for us to show that we do it differently. But therapeutic inertia, quoting Bevan, we know what happens to people and stay in the middle of the road. They get run down. Now, this is my summary. So deprescribing acknowledges the comorbidity and is the perfect marriage between clinical and cost saving. I'm putting myself out there. All pharmacists working in primary care should be running polypharmacy clinics for at least 1 session a week to improve patient safety and NHS sustainability. I think it's very easy for us to get involved in the reactive work all the time, while we should be working proactively as well to lessen the reactive work. Only via doing can we further develop our expertise in deprescribing. Healthcare professionals want the best possible outcomes for their patients, but according to the Hippocratic Oath, first, do no harm. 2 quotes to finish. This is a brilliant book. I don't know if anybody's had the opportunity to read it, by Dr. Adam Kay. This is going to hurt. Every single doctor, nurse, midwife, pharmacist, physio and paramedic needs to shout about the reality of their work. So this aspect of work is great. We're all doing it. It's new. There isn't an SOP to support us. Remember, they do an impossible job to the very best of their abilities. Even though that patient went to hospital, I was doing my best in trying to get him off the glipizide. Your time in hospital may well hurt them a lot more than it hurts you. I will remember his name till retirement. And finally, if we don't change our working practices, if we remain in the amber area and we don't venture into the red, I think that we're doing ourselves a disservice, but also we're not meeting the current needs of the NHS. So to finish with a quote again by Nye, the NHS will last as long as there are folk left with the faith to fight for it, and that also means that we have to change our practice according to the needs of what we're currently dealing with. That's it.